In this disease, there is bilateral diffuse alveolar damage, which ultimately leads into a dangerous complication called as ARDS. ARDS, it is acute respiratory distress syndrome. Let us see the important findings. This ARDS is characterized by acute shortness of breath, along with that hypoxemia and bilateral diffuse pulmonary infiltrates. Patient will have acute shortness of breath, and if you see his blood, oxygen will be less, and if you see his chest X-ray, it will be filled with infiltrates bilaterally. This phenomena is called as ARDS. The etiology can be classified into direct causes, indirect causes. Direct cause means the disease first starts in the lung, as a complication ARDS develops. Indirect means it happens in some other system as a part of systemic inflammatory response syndrome. These inflammatory mediators reach the lung, damage the lung, and result in ARDS. Let it be either direct or indirect. ARDS is just like Salman Khan's relationship status, always complicated phenomena. So write down direct causes. So direct causes, we have severe pneumonia, aspiration of gastric contents, near drowning, toxin inhalation, lung contusion. These are the various causes. Of ARDS. Coming to indirect causes, sepsis, blood transfusions, severe trauma, burns, pancreatitis. Write down this statement from Harrison. About 40 to 60% cases of ARDS are due to sepsis and pneumonia. What does this mean, students? In majority, the etiology of ARDS is infective. Majority of ARDS are caused due to infective etiology. About 40 to 60% cases. This is a statement given in your 20th edition of Harrison. About 40 to 60% of cases are due to sepsis and pneumonia. Based on the pathophysiology, ARDS is having some special names. What are the other names of ARDS? It is frequently called as non-cardiogenic pulmonary edema. It is called as non-cardiogenic pulmonary edema. It is also called as increased permeability pulmonary edema. ARDS, also called as low pressure pulmonary edema. Diffuse alveolar damage. Because ARDS frequently happens with septic shock. it is also called as shock lung. ARDS frequently happens with septic shock. It is also called as shock lung. Once you understand the pathophysiology, you will know the importance of these names. Like I told you, ARDS is frequently called as non-cardiogenic pulmonary edema. Whenever you see the term pulmonary edema, what is the first disease that comes into your mind? Cardiogenic pulmonary edema. Because of some left heart disease, your alveoli getting filled with fluid. Now ARDS is also a pulmonary edema, but there is no heart disease responsible for this pulmonary edema. First, let us see what is the pathophysiology of pulmonary edema, cardiogenic. Then you will understand how ARDS is different. Make a table, students. Pathophysiology. On one side I will discuss cardiogenic pulmonary edema. On other side non-cardiogenic, also called as ARDS. For a patient to develop cardiogenic pulmonary edema, most important is patient should be having some underlying left heart disease. First of all, let us see the body circulation. From the body, the deoxygenated blood reaches your right heart into the right atrium. From the right atrium, it goes into the right ventricle. From the right ventricle, there is a big vessel called as pulmonary artery. This pulmonary artery carries the blood to the alveoli. Your alveolus is the basic gas exchange unit. At the level of alveoli, all these arteries give rise to tiny structure called as capillaries. Now these capillaries will merge after gaseous exchange into a big vessel called as pulmonary vein. So this pulmonary artery will give rise to pulmonary capillaries at the level of alveolus. Once the gas exchange is done, all these capillaries will form pulmonary vein, and this pulmonary vein opens into left atrium. From the left atrium, it reaches the left ventricle, the blood. From the left ventricle, the oxygenated blood will go into the body. This is the basic circulation. Like I told you, for development of cardiogenic pulmonary edema, there should be an active left heart disease. Consider this patient is having severe mitral stenosis. There is narrowing of mitral valve like this. So whenever there is narrowing of mitral valve like this, there will be increased left atrial pressure. From the left atrium, this pressure can be transmitted backwards to the contiguous structure. What is the structure contiguous to left atrium back? Pulmonary vein. There will be increased pulmonary venous pressure. There will be increased pulmonary venous pressure. Now from the pulmonary veins, this pressure can be transmitted to the next contiguous structure called as pulmonary capillaries. There will be increased pulmonary capillary pressure. There will be increased pulmonary capillary pressures. Now for development of edema anywhere, students, what are the pressures that can be altered? Either increased hydrostatic pressure or decreased oncotic pressure. Now what is happening in the capillaries? Increased hydrostatic pressure. So from the capillaries, blood and fluid will start accumulating in the alveoli. Blood and fluid will start accumulating in the alveoli. This phenomena is called as pulmonary edema. Now because alveoli are filled with blood and fluid, patient will develop cough. This blood and fluid can be expectorated as pink frothy sputum. Pink frothy sputum. Then if at all the disease is not controlled at this level, the pressure in the pulmonary capillaries can be transmitted into the pulmonary artery, resulting in pulmonary arterial hypertension. And my right ventricle is never used to such high pressures. Your right ventricle can give up, resulting in right heart failure. So these are all a sequence of events. If the pressure is not controlled at the pulmonary edema level, it can transmit to the pulmonary artery. It can transmit to the right ventricle, ultimately causing right heart failure. Now what is the key event here? Increased left atrial pressure and the pressure getting transmitted backwards. Pressure getting transmitted backwards through contiguous structures. This mechanism is called as increased back pressure. This mechanism is called as increased back pressure. The important pressure to be elevated here is left atrial pressure. Now students, whenever I want to measure my right heart pressure, I can directly put a catheter from the jugulars into the right heart and measure. But such accessibility, such easy accessibility is not available for my left heart. So what I am going to do is, I will take a specialized catheter and I am putting in the jugular, from the jugular into right atrium, right ventricle, into the pulmonary artery, and in a small branch I am going to wedge this catheter. Now tell me students, any significant change in pressure in left atrium, can it be known by this catheter? Yes, because it will be reflected onto the pulmonary circulation. So this method of indirectly measuring left atrial pressure by wedging a catheter in the pulmonary circulation, it is called as pulmonary capillary wedge pressure. It is called as pulmonary capillary wedge pressure, PCWP. PCWP is an indirect measure of left atrial pressure in cardiogenic pulmonary edema. What happens to PCWP? There is increased left atrial pressure. It will be more than 18 mm Hg. It will be significantly high. It will be significantly high. That means more than 18 mm Hg. Coming to non-cardiogenic pulmonary edema, ARDS. Now what is the primary event here? Consider this is the alveolus and let this be the blood vessel. Now in ARDS there is damage to capillary endothelium. There is damage to capillary endothelium and alveolar epithelium. Capillary endothelium and alveolar epithelium at multiple sites in both lungs, bilaterally at so many areas. There will be damage to alveolar epithelium and capillary endothelium. Let us take, these are few areas of damage. Whenever there is a damage, there can be a leak like this. So whenever the capillary epithelium and capillary endothelium and alveolar epithelium are damaged, there can be formation of a leak like this. Through this leak, notorious cells in circulation called as neutrophils will gain access into the alveoli. Neutrophils will come into the alveoli. There will be increased permeability to neutrophils. Now tell me students, wherever neutrophils go, what is its function? Inflammatory damage and exudative fluid formation. There will be inflammatory damage. And exudative fluid formation. Now if you observe here, the end result here also alveoli filled with fluid. There is pulmonary edema, but it is not due to any left heart disease. That's why it is called as non-cardiogenic pulmonary edema. It is called as non-cardiogenic pulmonary edema. And there is damage at multiple sites. So it is called as diffuse alveolar damage. It is happening because of increased permeability to neutrophils. That's why it is called as increased permeability pulmonary edema. Now if you measure PCWP in ARDS, because there is no left heart disease, PCWP will not be elevated significantly. It will be less than 18 mmHg. In cardiogenic pulmonary edema, it is more or high. In ARDS, it is less. PCWP is less. So it is called as low pressure pulmonary edema. When compared to cardiogenic pulmonary edema, in ARDS, PCWP is low. So it is called as low pressure pulmonary edema. So we have discussed why it is non-cardiogenic, why it is increased permeability, why it is low pressure pulmonary edema, why it is diffuse alveolar damage. This is the brief pathophysiology. This is the brief pathophysiology and difference between cardiogenic pulmonary edema and non-cardiogenic pulmonary edema. Cardiogenic and non-cardiogenic. Now what does this diagram shows you? Into the pulmonary circulation. So from the right heart, jugular, right atrium, right ventricle into the pulmonary artery into a small branch. I have put a specialized catheter. The name of the catheter is Swan-Ganz catheter, also called as pulmonary artery catheter. Also called as pulmonary artery catheter. What is this method called as? Pulmonary capillary wedge pressure. What will it indirectly measure? Left atrial pressure. It indirectly measures left atrial pressure. Coming to ARDS diagnostic criteria. To call it as ARDS, already we have discussed. Patient will have acute shortness of breath within 1 week. Acute shortness of breath within 1 week. Second important thing. If you take a chest X-ray, there will be bilateral diffuse pulmonary infiltrates. One can notice bilateral diffuse pulmonary infiltrates. And the origin of edema. Is generally a non-cardiogenic pulmonary edema. It is non-cardiogenic pulmonary edema. Patient will have hypoxemia, hypoxemic respiratory failure. He will be in hypoxemia respiratory failure. When do you call it as hypoxemia respiratory failure? PaO2 less than 60 mmHg. But in critical care units, they don't just write PaO2. They compare it with the FiO2 of the patient. See, FiO2 is fraction of inspired oxygen. FiO2 means fraction of inspired oxygen. Now I am sitting in this room. What is the percentage of oxygen I am inhaling from this room? 21%. For calculation purpose, we take it as 20%. 20% if I convert it into decimals, it will be 0.2. So according to this ratio, now the definition of ARDS is not just PaO2 less than 60, it is PaO2 by FiO2 less than 60 by 0.2. 60 by 0.2 you get 300 mmHg. Now what is the benefit of this ratio? It can classify ARDS into mild, moderate and severe. If in the question you notice PaO2 by FiO2 ratio is in the range of 200 to 300. This is mild ARDS. If it is 100 to 200, this is moderate ARDS. If it is less than 100, this is severe ARDS. Frequently asked question, which of the following qualifies for severe ARDS? Your answer should be PaO2 by FiO2 ratio less than 100. PaO2 by FiO2 ratio less than 100. In the year 2012, in a place called as Berlin, these Americans and Britishers sat together and gave the same criteria with a new name called as Berlin 2012 criteria. As usual, we Indians were either not invited or we were not interested. Jokes apart, the new name for ARDS diagnostic criteria is Berlin 2012 criteria. It is the same thing. Acute shortness of breath within 1 week, chest X-ray showing bilateral diffuse pulmonary infiltrates, origin of edema, non-cardiogenic, PaO2 by FiO2 less than 300. So when they mention Berlin 2012 criteria, don't think it is something different. It is the same criteria because it was given in Berlin 2012. It is called as Berlin 2012 criteria. Now coming to the treatment of ARDS. Treatment, you should start treating the underlying cause. If it is due to some pneumonia, you should start giving antibiotics, and by the time a patient with ARDS reaches me, he is already in respiratory failure, it is a complication. He ultimately requires mechanical ventilation. In that mechanical ventilation, what is most important strategy you must know, students. So write down treatment. Treat the underlying cause. Treat the underlying cause. And this patient eventually requires mechanical ventilation. In that mechanical ventilation, what is most beneficial or recommended? The answer should be low tidal volume. Low tidal volume in the sense 4 to 6 ml per kg body weight. Low tidal volume mechanical ventilation. Low tidal volume mechanical ventilation. Why low tidal volume mechanical ventilation? To avoid ventilator associated lung injury. Associated lung injury. Now what is the normal tidal volume? We can take it as 500. If you take weight of the patient as 50 kgs, it will be roughly about 10 ml per kg body weight. Initially, in the early 1970s and 80s, when they identify ARDS, they were giving routine tidal volumes. Once they were giving routine tidal volumes, majority of studies have shown that ARDS lungs were very sensitive. When we are giving routine tidal volumes, the lungs were getting damaged. So that's why they started to give low tidal volumes. Instead of 8 to 10 ml, they started to give 4 to 6 ml per kg body weight. After giving low tidal volumes, majority of studies now have shown that ARDS lungs were tolerating low tidal volumes very well, and it was also associated with some survival benefit. That's why from then onwards, if there is ARDS, they concluded that most beneficial or recommended strategy is the low tidal volume mechanical ventilation. So why it is done? To avoid ventilator associated lung injury. Then later on, we also understood that not only the volume should be controlled, the pressure given to the small airway should also be controlled. This plateau pressure is nothing but the pressure delivered to the small airways. So that should also be controlled. It should be less than 30 centimeter H2O. See, all this you can adjust on a ventilator. So no need to worry. All this you can adjust on a ventilator. So why we give a plateau pressure less than 30 centimeter H2O? Again, to avoid ventilator associated lung injury. And then you should also provide PEEP. What is meant by PEEP? Positive and expiratory pressure. So PEEP should be provided. PEEP is positive and expiratory pressure. What is the advantage of PEEP in ARDS? Like I told you previously, in ARDS, both type 1 and type 2 alveolar epithelial cells are damaged. Whenever type 2 cells are damaged, the function of surfactant decreases. So the alveoli will close at expiration. Now you need a pressure to keep the alveoli open even at end expiration. So this PEEP is something functioning like a surfactant which will keep the alveoli open at end expiration, and it will improve oxygenation. So this phenomena is called as positive end expiratory pressure. PEEP is nothing but positive end expiratory pressure. It is given to improve oxygenation in ARDS. And you should sedate and completely knock down the patient, paralyze the patient to relax the patient and facilitate ventilation. Why this sedation and neuromuscular blockade is important? Now if you don't properly sedate the patient, if you don't completely knock down the patient, so patient will be moving, he will be trying to remove the tube, and your purpose of ventilation will not be achieved. So there will be patient and ventilator asynchrony, and ventilation will not happen properly. So completely knock down the patient. Let the ventilator do its job without any problem, without any hindrance. So sedation and paralytics to relax the patient and facilitate ventilation. And glucocorticoids may be beneficial. We know that in ARDS there is neutrophil mediated inflammatory damage. Once you give glucocorticoids, it can decrease the inflammatory response. But be careful while giving glucocorticoids in all patients. If at all there is an active bacterial infection, it can flare up the infection. So you should have that clinical judgment. So whether to give glucocorticoids, yes or no. So you should see if the bacterial infection is controlled or there is adequate antibacterial coverage. In that cases, glucocorticoids can be given. But I don't say that it should be given. So depending upon the clinical scenario, where there is no active infection, glucocorticoids might be beneficial. Unlike any critically ill patient, you should take care of patient's fluid and electrolyte balance. You should make sure he is not dehydrated or overhydrated. He is not having hypotension or hypertension. And electrolytes such as sodium, potassium, they all should be maintained within normal limits. But if they ask you most beneficial or recommended strategy, the single best answer is low tidal volume mechanical ventilation. Low tidal volume mechanical ventilation. Up to the early 2000s, whenever we were having a patient with ARDS, especially severe ARDS, this is what we used to do. We used to ventilate, wait, and let God decide what to do next. There were actually no options available for severe ARDS patients. But recently there are few methods which have brought benefit even in severe ARDS patients. Let us see what are those ventilatory strategies that can be helpful in severe ARDS patients. So the first ventilatory strategy is this device. Now what do you see here? There is a patient. There is a patient here, students. From his body, deoxygenated blood. From his body, deoxygenated blood is sent into a mission. It is sent into a specialized mission. What is the name of that mission? It is called as membrane oxygenator. It is called as membrane. It is called as membrane oxygenator. Membrane oxygenator. And in the membrane oxygenator, there will be oxygenation of blood. Oxygen is added to the blood, and oxygenated blood is sent back into patient's body. And oxygenated blood is sent back into patient's body. What is this phenomena called as? Because it is happening outside the body, it is called as extracorporeal. outside the body, it is called extracorporeal, and there is a membrane oxygenator involved. So the method is called as membrane oxygenation. In simple words, it is written as ECMO, extracorporeal membrane oxygenation. Let us see what is the principle of ECMO. So in ECMO, deoxygenated blood from patient's body is sent into a device called as membrane oxygenator. From the membrane oxygenator, oxygenated blood is sent into patient's body. This ECMO is considered as beneficial, especially in severe ARDS. It is beneficial especially in severe ARDS. Then what is the disadvantages of this ECMO? So main disadvantage is its availability and affordability. If there are 100 hospitals, only few hospitals will have ECMO. Even though the mission is available, it is not that affordable. Per day, only the mission's charge is about 5 lakhs. Along with that, doctor's charge, nurse charge, bed charge, injection charge, ward boy charge, and you don't know for how many days patient should be kept on this mission. So whenever I say something is not available, not affordable, the next statement is that is not really practical in our country. To overcome all these difficulties, there is another method routinely practiced. What is this method? Normally, I put a patient in supine position and ventilate. Now, this patient is in prone position. He is connected to a ventilator. What is this called as? Prone ventilation. This has become very famous because of COVID. Prone ventilation. By proning the patient, there will be decreased diaphragmatic compression. Over basal alveoli. That results in increased participation in gaseous exchange. That causes overall improvement in oxygenation. And this prone position, to get benefit, it has to be done consecutively, continuously for 12 to 16 hours. And studies have shown that this is also beneficial, especially in severe ARDS. Let us see what is the mechanism behind prone ventilation. Now, by proning the patient, see, whenever patient is in supine position like this, his diaphragm will slightly come up and it can compress the lung bases. Now, whenever patient is lying in prone position, now the weight of the diaphragm is facing downwards. So when the weight of the diaphragm is facing downwards, the basal alveoli will start expanding. Already this patient with ARDS, majority of lung is damaged. Now if some good alveoli from the lung bases starts to take part in gaseous exchange, there will be increased gaseous exchange and overall improvement in oxygenation. In simple words, by putting the patient in prone position, the lung bases can start expanding, take part in gaseous exchange, and it will improve the oxygenation. And to get benefit, It has to be done continuously. If you just do for 1 or 2 hours, there will be no benefit. It has to be done for 12 to 16 hours, and this is also beneficial in severe ARDS, just like ECMO. Now coming to the treatment algorithm for ARDS. So let it be any patient. First important should be low tidal volume mechanical ventilation. If patient is improving, that will be sufficient. If patient is not improving, if your institute has ECMO, you can go for ECMO. If ECMO is not available, prone ventilation is also a viable option. Prone ventilation is also a viable option. This is how a chest X-ray in a patient with ARDS looks like. You can notice bilateral, top to bottom, side to side, diffuse infiltrations. Bilateral, diffuse. Pulmonary infiltrates are seen. So this is the classical chest X-ray of a patient with ARDS. Bilateral, diffuse, pulmonary infiltrations. Let us see some cases. A 30-year-old patient presented with features of acute pancreatitis. Few days later, he developed dyspnea. His chest X-ray is shown below. The probable respiratory failure is. How to approach? In this question, there is pancreatitis within few days, acute shortness of breath, and chest X-ray if you notice. Bilateral diffuse pulmonary infiltrates. Bilateral diffuse pulmonary infiltrates, and mostly because of this infiltrates he might be having even hypoxemia. So this in combination is suggestive of ARDS. This is suggestive. If you have acute shortness of breath, bilateral diffuse infiltrates with a risk factor of pancreatitis, it might be an ARDS. In ARDS, what is the type of respiratory failure? Your answer should be type 1 respiratory failure. Then case number 10. A 25-year-old female had severe peripartum bleeding, received 20 packed RBCs and had to be intubated for respiratory failure. The ventilation settings, tidal volume 500, frequency of breaths 15 per minute, echo was normal, she weighs 60 kgs, chest X-ray is showing bilateral diffuse pulmonary infiltrates. First of all, what might be the diagnosis? Patient received RBC transfusion, later respiratory failure, and chest X-ray is showing diffuse pulmonary infiltrates. So what is this? Transfusion related acute lung injury. Nowadays we are not using the term acute lung injury, we are just calling it as ARDS. This is an ARDS developed due to blood transfusion, and you can also see the cardiac function is normal, so most probably it is non-cardiogenic pulmonary edema. True regarding the case. Pulmonary embolism is the diagnosis, it is false statement. PCWP will be more than 18? No. This is ARDS, it will be less. Decrease the ventilator frequency to 10 breaths per minute? No point, because already the respiratory rate is maintained at 15 per minute. No need to decrease it below the physiological limits. Decrease tidal volume to 360 ml. Decrease tidal volume. So this is ARDS, low tidal volume mechanical ventilation. Patient's weight is 60. What is permissible tidal volume? 60 into 6. 360 ml. The best answer is decrease tidal volume to 360 ml. Option C. Option C will be the best answer. This is an ARDS, and most important will be low tidal volume mechanical ventilation, students. When you are not interested from front, you look backward. That is nothing but prone ventilation. So this was the previous supine ventilation. Now because of COVID pandemic, we are more attracted to prone ventilation. So regarding prone ventilation, all are true except meta-analysis of ARDS have suggested that outcomes with the prone positioning are better in patients with severe hypoxemia. It is true statement. Patients placed for 16 hours, yes. In many trials, mechanical ventilation in prone position improved oxygenation. Yes. Lung compression by diaphragm increases in prone position. So this is false statement. Actually, lung compression tends to decrease and lung bases expand. The answer is option C. So lung compression by diaphragm generally decreases by prone position. Generally decreases by prone position. So this is regarding ARDS. You should know the ventilatory strategies, how to identify clinically, radiologically, and the treatment options.